So without further any ado, I'm going to introduce Dr. Kaye and turn the screen over to him. So Dr. Kaye is the founder and executive director of the Eating Disorder and an Eating Disorder Program professor at the University of California, San Diego Department of Psychiatry. He was recruited to UC San Diego faculty from the University of Pittsburgh School of Medicine, where he was research director of the Eating Disorder Program and where he received an NIMH Senior Scientist Award. Dr. Kaye's current research is focused on exploring the relationship between brain and behavior using brain imaging and genetics, and developing and applying new treatments for anorexia and bulimia nervosa. He is the principal investigator for an international multi-site collaboration on the genetics of anorexia and bulimia nervosa. He has an international reputation in the field of eating disorders and is the author of more than 300 articles and publications. He attended Ohio State Medical School, trained in neurology at the University of Southern California, and trained in psychiatry at the University of California, Los Angeles. Dr. Kaye was then a fellow and research physician at the National Institute of Mental Health for 7 years, where he conducted research on appetite regulation, behavior, and treatment for eating disorders. As director of the University of California, San Diego Eating Disorder Treatment and Research Program, Dr. Kaye and his clinical team are treating anorexia nervosa and other eating disorders with an innovative, intensive treatment program that approaches the problem on multiple levels, including medical, psychological, psychoeducational, and counseling of the family as a key support group. We're very honored to have Dr. Kaye here presenting for us, and I will turn the screen over to you and see you back here in about 50 minutes.
Well, thank you very much, and thank you for that kind introduction. I'm going to talk about the question about whether anorexia is actually an eating disorder. The field calls this an eating disorder, but I'm not sure that many people believe that there's actually a primary disturbance of appetite regulation. So this is going to be a little bit different of focus today, maybe compared to the other talks, but why don't we go ahead and get started here. So I'm sure you're aware that anorexia has a lot of symptoms that we don't really understand very well. I mean, and of course, it has onset, it tends to be in adolescence, often near in time to puberty. There's severe restricted eating and emaciation, but at the same time, people are preoccupied with food. How do you explain that? They tend to be excellent students, but they have limited ability to learn to change, especially when they're ill. They have body images, distortion of fear of being fat. And the thing that's really concerned us the most is that there aren't any proven treatments that we know reverse core symptoms. Family-based treatment, which we do a lot of, is very helpful, but it doesn't really change the core underlying symptoms of anorexia. And part of the problem that makes it such a difficult disorder to treat is there's often a lot of denial and resistance to treatment. And the course is, it's both good and bad news. The good news is that many people, 50, maybe 60% of people actually recover, have a very, good recovery, but this may take 5 or 10 years or even longer. And then there's a group of people that that are either partially recovered or even remain chronically ill. And there's a group of people, maybe as many as 5 to 10%, that die from an eating disorder. And again, we don't have really powerful treatments. So the question is, if we understood the mechanisms of the risk and poor outcome, would this help us develop more effective treatments? Now, let me go back 100 years, because in some ways psychiatry is where the rest of medicine was 100 years ago. And that is, 100 years ago, if you started coughing and you went to your doctor, they might, make a diagnosis on something like the color of what you're coughing up. Is it red? Is it yellow? Is it white? Today we know that there's many different things, causes of a cough. You could have an infection, and it could be bacterial or TB. It could be a tumor. It could be some kind of lung disease or trauma or any other number of things. And that the color of what you bring up, really is dependent to some extent on the course and, of what you're having. It really isn't diagnostic. And because now we're able to kind of diagnose these different etiologies, we can more effectively treat any kind of cough. Now, we're not that way in psychiatry. In psychiatry, we're still looking at symptoms, anxiety, depression, things like that. There isn't any one, you know, portion of the brain that causes anxiety and depression. It's much more complicated than that. We have to really get to a point where we're starting to understand brain and behavior and new constructs. And that is, what do I mean by constructs? This is getting beyond just looking at symptoms, but actually trying to understand as best we can how behavior is encoded in neural circuits and how we make decisions guided, for example, guided by reward and punishment. And I'm going to talk about some new terms today, particularly how motivation or initiation is wired into the brain and how that may play a role in eating disorders. So to really kind of go on to the next generation of treatments and a new understanding of the brain, we're going to have to change our language and the way we understand it. And I'm going to give you kind of a short course in trying to do that today. So let me go back another step. And for those of you who have 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 had anorexia or have children with anorexia, and this also applies to some extent to people with bulimia, I'm going to go through a list of traits here. I'm going to ask you, were these present when you were a child, 8 years old, 10 years old, but before you ever developed an eating disorder? How many of you had any of these traits, or your children? Were you achievement oriented? Did you want to get all A's as a child? Were you perfectionistic as a child? Things had to be done just a certain way. Were you sensitive to criticism and punishment and mistakes? Were you an anxious child? Did you worry about what might happen? Always worried about consequences. Were you harm avoidant? You had difficulty with uncertainty and novelty and change in social situations? Were you obsessional? Were things, you kept your desk in a certain kind of way, everything we had at a certain place, the exactness was important. As a child, did you have, concerns about your body states? Did you, some children with anorexia complain about the way textures or, labels feel, or touch, they don't like to be touched. And there's a group of people that are impulsive and overreactive and emotional. Now, it's not like everybody with anorexia has all of these symptoms in childhood, but what we find is people tend to have one or more, not everybody, but most people have one or more, and people tend to have different patterns. So we think that these are somehow vulnerabilities that create, somehow end up resulting in developing an eating disorder. Now, the question I always ask people is, if you have these kind of traits in childhood, why would you develop an eating disorder? I mean, what does that mean? I mean, how do you connect the two? And, it's very hard to answer, and the field hasn't been able to answer this, so I think it's kind of ignored that. But that's what I'm going to talk about today, how these traits may result in why you end up with restricted eating or restricted eating and binging and purging. So what's different about eating behavior and anorexia? And, we do a lot of family-based treatment. Certainly not the only thing we do, but we do a lot of family-based treatment, which used to be called Maudsley. And, when families come in to see us, they're often, the TV game Family Feud, where two families compete against each other. Well, this is kind of like an inter-family feud. It's not like it's parents and their children are often very stressed and angry at each other, and a lot of conflict over issues like eating. And the reason I bring up this issue of Family Feud is because what Family Feud does is the producers create a list of what's the most popular kind of answers for any one kind of question. So let me ask you this: if you don't have an eating disorder, how do you feel when you go without eating a day for a day or two? Now, I would say that 80 or 90% of the people, 95% of the people that we talk to that don't have an eating disorder say it's uncomfortable. They feel irritable and tense when they're hungry. It just isn't a pleasant state. And there's pleasure and reward in their eating. In fact, if you get very hungry, that first bite of food really tastes very good. And then you ask their children or some people with anorexia, how do they feel about eating? And there's a large literature on this. And what many, not everybody, but most people with anorexia will say, there's something about eating or thinking about food that's uncomfortable. It's anxiety producing. It just creates uncomfortable kinds of feelings. And there's something about not eating that maybe makes the anxiety go away, may even be empowering, or at least it doesn't create more anxiety. So this is a very different kind of pattern that we see where, and I think this is very hard for families because, their natural instinct is, yeah, I get hungry, food tastes better, I'm motivated to eat. And why isn't that happening in my children? Just doesn't make sense to me. So we really want to ask the question about how hunger, uh, what happens when people with anorexia aren't eating? They should be hungry and food should be more rewarding. Now, I'm going to go back a step and I'm going to talk about animals in the wild because, animals, mammals, and for that part, reptiles do a pretty good job of feeding themselves. They're able to find food. And there are mechanisms I'm going to talk about that we share with animals that may be responsible for this. So what happens is that, when a rabbit is staying in their little den or hole there on the ground, they may be very safe, but when they get hungry, uh, food becomes they feel the same way. It must be uncomfortable for them, and food becomes more rewarding. But for an animal like a rabbit, food is precarious. You might get eaten by a predator. In fact, in captivity, a rabbit may live for about 8 or 9 years. The natural life of a rabbit in a field is about a year and a half. They don't live very long because they do get eaten by a predator. So what do we know about these brain circuits? So with just to kind of save time, I'm going to talk about the mammalian brain and the human brain. And mammals and humans, very simplistically, let's see if I can get this to work here. Very simplistically, this is the front of your brain. This is the brain stem. Your eyes would be right here, nose and mouth. And this lower part of the brain here, the subcortical area, is a part of the brain that we share with mammals, and it contains the limbic system. And animals have emotions, they have a certain amount of memories, they have habits, they've got attachments. Those kind of um, behaviors are wired in these subcortical areas. What's different about humans is we have a lot more cortex than mammals do. And that's what makes us uniquely human. It gives us our language, our ability to kind of think abstractly and imagine things, and consciousness and reasoning and rationalization. To some extent, animals have that, but certainly not the way humans have it. And so the question we really want to ask is, what about these subcortical areas of the brain that we share with animals? How may they play a role? So let's talk about those subcortical areas and how do animals find food and avoid being food. So what happens for an animal and for human beings, for that matter, is when our body, processes food, fats, carbohydrates, and proteins. And when we start to run into deficits, when we're hungry, and we're running out of carbohydrates, or we have a decrease in our body fats, that actually there's a lot of signals, a lot of hormones that get sent to the subcortical area of the brain that tell us that we're hungry and we should, find some food. And this also interacts with other subcortical part of the brain that tell us about other kind of internal body states. We're getting signals from a pain in our stomach, or that we have to use the bathroom. And it also gets signals about the emotional state we're in and instinctive kind of drives. And we put this together to recreate a drive to eat, but we also pay attention, and the animals do too, to the external world and the risk and the rewards of eating and finding food. And so, if an animal is very hungry, but there's a reward, there's a risk out there, they're liable to be able to inhibit that eating behavior because they might get eaten by a predator. So rewards and punishments are very important. And simplistically, uh, when something is rewarding for people and for dogs, it's the same thing. We learn to do it more. When something is punishing, we learn to do it less. And these systems are wired in the subcortical part of the brain. And, there may be biases in the way they work. Some people are very oversensitive to rewards, and they may be prone to overeat or use drugs or, be motivated by other kinds of rewards like money. And some people are oversensitive to to punishment, things going wrong, and they may be sensitive to something, to risk, to some aversive kind of situation. So we're all kind of wired a little bit differently here. And these traits that you're seeing in childhood and anorexia are probably um, the way that these systems are wired in the brain showing up in childhood. So let me talk a little bit more. This is going to get a little bit technical, but let me talk about these systems and try and explain them simply. So you have these subcortical areas of the brain, and these are actually the brain regions that are in the subcortical area of the brain, and I've kind of broken them down here into really kind of what they do. So when you taste food, for example, something sweet, there's an area in a part of the brain called the insula, which is kind of deep to the temporal lobes, that has a taste circuit in it, and it basically tells you have tasted something sweet. But it also tells you about other tastes, and it also tells you about other body states. So that's where you get messages about whether you have a pain in your stomach or you have to go to the bathroom. And another part of the insula, the anterior part of the insula, is the part that integrates that with the emotions that you're feeling and the drives. And I'll come back. The homeostatic drives are things like, getting messages that you're at an energy deficit and you should find some food. And then what this does is this connects, and this is actually a brain circuit. It connects with another area of the brain called the striatum, and there's a part of it, the limbic region, that's very important for kind of motivating and rewarding us to do things. And so you take these signals about energy deficits and being hungry, and you're motivated to go out and find some food, and it's rewarding. But there's another part of this striatum that connects with that that's very important for action selection. And I'll talk about that next, which is deciding exactly what you're going to do. And then the motor striatum is responsible for actually carrying out that activity, and initiating eating or running away from a threat. And again, these are the animal circuits that we share pretty directly with animals. So um, what happens is that decreased energy stores send signals like insulin, leptin, and ghrelin to this area, and then the striatum makes decisions. Now, how the striatum does that is it allows you to select one thing and inhibit others. You have to have some part of your brain that kind of helps you make a decision and carry out. You can't do everything at the same time. It's better to do one thing at a time. So this is the part of the brain that focuses your attention, your emotional participation on one single event, and simultaneously suppresses and fades out other happening and motivational events. So what happens when people and animals get hungry is hunger increases the motivational aspect of food and money and reward. It activates these regions associated with reward and motivation in the striatum, and it reduces the part of the striatum that is responsible for kind of inhibitory self-control. And so when you're hungry, this actually changes your behavior. Studies have shown that when humans are are hungry, they're less risk averse, and that makes sense. Things are more rewarding, they have less inhibitory control. Animals, we've known for a long time that if you starve an animal, they'll be more prone to use drugs of abuse. Now this makes sense. The reward system, which is very important for where drugs actually, most of them act on this reward system. They become more sensitive to that because reward is amped up. And my mother used to say, don't go shopping when you're hungry because you're liable to buy things you might not buy otherwise. So the question we asked is, do people with anorexia have an abnormal response to hunger? So just to kind of repeat this, because I know it's complicated. So we're looking at this motivational action selection, motor execution system. When animals are hungry, they're getting signals that food is rewarding and they're motivated to go out and look for food. But if there's something aversive going on, they're going to inhibit that behavior and they're going to run away. Very simple. It's, and the animals that don't do this very accurately probably don't stay in the gene pool. They get eaten by a predator. So the study we did was published earlier this year in the American Journal of Psychiatry, and these are my colleagues that worked on the study with me. And the way we did this study is we had people with anorexia come into a building that we have on campus, a research center where they could live for 3 days. And they stayed there for 3 days. And we fed them all their meals. And on one day, we had them fast for 16 hours. And on the other day, they ate normally. And we had everybody eat actually the same foods and the same amounts of food proportional to their body weight. So that this is very well controlled. We knew that they weren't eating or not eating otherwise. And the way we activated this circuit is we had them lay on our brain scanner, and we put a tube in their mouth, and we gave them repeated tastes of sugar water. And the reason that we did that is taste of sugar activates the taste cortex, and the insulin activates this whole kind of circuit. Now, the way we use this brain imaging called functional MRI, magnetic resonance imaging, and what this does is this really allows us to measure when a circuit kind of gets activated, and because when a circuit gets activated, it uses more blood flow and more oxygen. Actually, it's pretty similar to what happens if you're exercising. If you move your arm and the muscles in your arm start moving, what happens is they need more blood flow and more oxygen to actually keep the machinery of the cell active and move that cell. And the same thing happens in the brain simplistically. When you activate a circuit, you use more blood flow and more oxygen, and this is a way of kind of reflecting the activity of a brain circuit. Now, an important thing about this is that we looked at women who were recovered from anorexia, not ill. And the reason that we did that is that we thought, and there's good evidence, that when people are malnourished, there's going to be alterations of this circuit, and we couldn't tell whether this is cause or consequence. So we looked at people who recovered from anorexia with the idea being, if this is really a trait, it's not going to go away even when people recover. And so these were the CW, or the control women, the RAN, recovered anorexics. These are people that were in their 20s, normal BMI, but you can see that people with anorexia, even after recovery, tended to be somewhat more anxious and harm avoidant. Harm avoidance is a trait that's a mixture of anxiety and inhibition and flexibility. It's a measure of risk avoidance. And interesting, we asked people if they would tell us how hungry or they were on the day that they fasted and the day that they were fed, and the controls and the anorexics looked identical. That was interesting. People with anorexia could very well tell when they were hungry or not. That wasn't really the issue, and I'll come back to that. So this is the main finding. Now, the main finding was in this part of the striatum that's very important for kind of motivation and reward. And this is the finding that we had in the healthy control women on the day that they were hungry and the day that they were fed. And just as we expected, on the day that they were hungry, the healthy control women showed more activity in this reward and motivational circuit than they did on the day they were fed. No surprise, that's what we expected to find. But what we found in people with anorexia was very different. And so this is the people with anorexia on the day that they were uh, hungry and the day that they were fed. And the big finding here is that on the day that people with anorexia were hungry, they had much less activity in this motivational reward circuit than the control women. Interestingly enough, on the day we were fed, the people with anorexia look just like the control women. There was no difference there. It's really the issue here is a problem when people are hungry. They're not getting, the brain isn't getting signals about motivation. And we looked in other parts of this circuit, and we looked in the anterior insula, this part that's very important for kind of integrating with emotional and homeostatic drives, and saw exactly the same thing. It was really on the day that they were hungry that people with anorexia had less activity. And when there's a way that to look at the connectivity between the insula and this limbic striatum, and we saw that there was also decreased connectivity signals between these two parts of the brain, again, on the day that they were hungry, not the day that they were fed. So what does this mean? Well, there's different ways of looking at this. Some people may be having a failure to sense body state signals or hunger or accurately integrate with emotion or drives. And it may be that other people, or maybe everybody, also had impaired motivation and ability to kind of initiate a response when they were hungry. Now, let me show you a little bit of data that actually supports how important these areas of the brain are in terms of eating behavior. I'm going to talk to you about another study that was done in anorexia that actually looked at what happens when when you're hungry, when you haven't eaten for a while. And, when you haven't eaten for a while, some of these signals, they didn't particularly look at these signals, insulin, leptin, and ghrelin, but what they looked at was the hypothalamus, so the part of the brain that these signals go to, and the hypothalamus then interconnects with the anterior insula and limbic striatum in sending signals about motivation. And so this is a study that was done, just published also earlier this year out of Germany. And what they did is they put a tube into the stomach of people with anorexia and healthy controls. And they were very hungry, and they did this study twice. And one day they just gave them water. On the other day, they gave them an infusion of sugar water. And what they found is that in the healthy control women, that when you gave them sugar compared to water, there was reactivity to the hypothalamus, this area of the brain that responds to these kind of signals about how energy stores showed a response. And also there was it showed an increased response in the area of the brain, the rewards, the reward and motivation area of the brain. But people with anorexia showed neither. They did not show a hypothalamic reactivity to sugar water, and they didn't show a connectivity between the hypothalamus and this brain reward circuit. This is very similar to what we're seeing here. There's a failure to respond when you're hungry to signals that you should be responding to that drive eating behavior. Now, we also see something similar in people with major depression. Now, people with major depression, a group of these people tend to stop eating and lose weight, and another group of people actually overeat and gain weight. What's going on in their brain? Well, it turns out that the people that have decreased appetite have decreased activity in their insula areas, part of the brain that's very important with kind of hunger signals and integration with emotion and drives. And the people that overate had increased signals in this motivational aspect of the brain and reward aspect of the brain. So this makes perfect sense. This is very consistent with what we're seeing in people with anorexia, and it just points out how important this area of the brain is in regulating appetite and weight in any number of other disorders. So in summary, there's a lack of appropriate response to food when hungry. People can't seem to translate this into initiation and motivation to eat. And, it starts to raise questions about, why it's so hard to engage people with anorexia in treatment, and often their lack of insight and motivation to engage. And, that's probably a talk for another time, but we think this is giving us clues as to better kind of approaches. Now, let me talk a little about anxiety. And Heather Howard, who I think is on at the session, and myself and Guido Frank did a session at the Academy Eating Disorder ICD conference back in 2018 on anxiety. And Heather did such a nice job of explaining anxiety in anorexia. I just thought I would quote her briefly. Heather says she felt like she was constantly on red level high alert. And there was no distinction in her mind between events that were life-threatening before versus life-annoying. She reacted as if everything was a real crisis. And her anxiety influenced her eating behavior. She discovered she restricted food. She felt less anxious overall. So what do we know about anxiety? How does that play a role? And where's that coming from? So part of the study that we did is in this next part of this item that's very important, action selection. We found a very strong, look, for behavior, this is a very strong correlation. And that is that in this measure of harm avoidance, this measure of anxiety, inhibition, and sensitivity, the more harm avoidant people were, the lower that signal was through this part of the brain. Now, without going into a lot of detail, this is particularly a part of the brain that's very important in initiating eating behavior, taking that motivational signal and actually initiating the act to eat. There's animal studies that suggest that that's true. So what it's saying, there's something about anxiety and inhibition that's kind of blocking, the ability to eat. Now, another thing that we know about this part of the brain is that dopamine, the striatum, dopamine is really a very important neurotransmitter for modulating behavior. And people say, well, dopamine is kind of a reward signal. That's not quite true. What it is it's basically a very important signal for kind of approach behavior and learning, but economic decision making. It's very important for kind of learning from reward to reward predicting stimuli, as well as the uncertainty associated with rewards. And so there's actually data suggesting that there's alterations of dopamine activity in people with anorexia, particularly present even after they recover. And so dopamine, there's a very actually relatively small number of cells in the brain that contain dopamine, and they send dopamine particularly to the striatum and to the orbitofrontal cortex, which is also very important for decision making. So we did a study at another time where we gave people with anorexia and control women's one dose of amphetamine. Now, what amphetamine does is it releases a lot of dopamine all at once. And there's a way, there's another imaging study that we can do that actually that measures the amount of dopamine being released in the brain. And what we found in the control women is that the more dopamine they released, the better they felt. And this was in this part of the striatum that's very important for motivation and reward. Again, not a surprise. Other investigators have seen this. People like amphetamine, makes them feel good. But when we gave this to people who recovered from anorexia, what we found was something very different and consistent with the data I've just told you. The more dopamine they released in this cognitive state and the part that's very important for action selection, the more anxious they felt. Um, and this is very consistent with saying there's something very different about the wiring of brain that people with anorexia, and they're very prone to kind of feel anxious about things and not, not prone to really feel rewarded about things. Um, this is a very small number of subjects, but this is a very difficult study to do and extremely expensive, so we couldn't do it on a lot of people. So just to kind of recapitulate here, um, what we're looking at is this circuit, and people with anorexia are probably getting not a very powerful signal about reward of food when they're hungry, and they're getting a very strong aversive signal about food and the risk of food, which makes very little sense if you're a human, but actually if you're an animal living in the wild, it makes a lot of sense, because that knowing when you're in a risky situation about food and there's something aversive going on is very important for inhibiting your behavior and not eating and getting out of there, and not becoming a meal for a predator. Now, we know from other studies of people with anorexia that this is, true. We've seen this over and over again. People with anorexia tend to have decreased reward and motivation. They underconsume not only food, but drugs and money. They have decreased reward sensitivity. And people with anorexia have increased inhibition and anxiety. They're highly sensitive to punishment. They're highly harm avoidant. They're over concerned with consequences. Uncertainty and change is very difficult for them. They have a higher error detection. They're perfectionistic. And so, what we think is going on here is that people with anorexia on a very subconscious level, let me tell you, learning from reward and punishment is pretty much subconscious. You actually can learn a lot from about reward and punishment without actually thinking about it. Again, it's a talk for another day. But they're getting signals that there may be something about food that's actually, they're miscoding it as risky. There's something about riskiness and danger of food. I've spent decades now treating people with anorexia, and I look at these little girls that are, standing there screaming at the top of their lungs about having to eat a meal, and they're terrified. And and that was beginning to make more sense. Let me talk about the benefits of this trait. You may look at me and go like, "What are you talking about? How could there be benefits?" Well, this is actually, these are some valuable traits just depending on your environment. This is a trait I describe it as enhanced alarm. These are people that have a bias. They're much more sensitive to risk reward. You were living 50,000 years ago, or you're a rabbit living out in a field. If you need to kind of be aware of danger or error or change and uncertainty, something that might hurt you, and be able to react to that. And have a repertoire of alternative plans if the worst happens. Mother Nature doesn't care if you're happy. It cares that you stay alive and you pass your genes on. If you don't pass your genes on, you're simply not going to pass on, certain traits. And so there's really kind of a benefit, I think, to animals and maybe our ancestors thousands of years ago to be very sensitive to things going wrong and having, plans to deal with it if that happened. If you were, these are the people that probably stayed alive. But the problem is that people with anorexia can't turn it off. It's an extreme, and certain diversions like schoolwork and exercise, can be helpful. Now, one of the things that we're beginning to find is that uh, how do people get better? 50-60% of people get better with anorexia, and these traits don't go away, but we think that they may be learning to kind of live with them, or have develop certain kind of coping strategies to be able to live with these kind of traits and tolerate them and manage them. And that's what we're doing in our treatment program. We're starting to come up with what are more constructive coping strategies for dealing with these temperament traits that you can't change. The good news is that we've observed, and we've published a paper that Heather wrote that's in press on actually that this might be a benefit in some ways, that people with anorexia, when they get well, actually tend to do very well in life. And they may have a competitive advantage in certain profession. being achievement oriented, paying attention to detail, concerned about consequence, self-discipline, is probably an advantage in engineering, medicine, finance, research. I'm a researcher primarily, and I can tell you it's a very competitive field. I've never had an eating disorder, but I tend to be kind of perfectionistic and obsessive. I can tell you all my research colleagues are perfectionistic and obsessive, and it's a necessary trait to be able to be competitive. So there's certain benefits to these kinds of traits. And so, I think the good news and the message I always try and give families is, you may struggle with your child with anorexia 2 years, 5 years, 10 years, sometimes even longer. You can't give up. People do get better. And when they get better, even, at times when they've had a very difficult course and been in and out of the hospital, and, there's a lot of conflict with their families, they do get better. When they get better, they actually tend to do very well in life, and they kind of heal all those kind of problems they've had with their families. And, I've never seen anybody with anorexia, who's recovered that hasn't kind of, really kind of, made peace and made up with their family, and actually is often very grateful that their family insisted they be in treatment. And they'll say, look, I just don't know why I was kind of acting this way. So I think that this is very important that we, families hang in there, and help their children recover. So let me talk a little bit about therapy. Now, what can we do with this new knowledge? Well, one of the things that we can do is psychoeducation. So, and that's important. It destigmatizes this disorder and says, look, there's a very powerful biology going on here. We're starting to understand the mechanisms, and destigmatizes it so people can feel okay about getting treatment. This is helpful for families. I'm not so sure when people are ill with anorexia, it's that effective. So what we're trying to do is come up with kind of a menu of constructive coping strategies that help people begin to motivate and initiate eating behavior, how they can kind of better manage sensitivity to punishment, and because people with anorexia are very sensitive to change and uncertainty, how families can help kind of externally kind of predict events and have high structure that may help people manage this anxiety. And then medication to reduce anxiety. So let me talk a little bit about medication. As I mentioned to you, there's some evidence that dopamine is altered in people with anorexia, and that dopamine is related to the anxiety that they're feeling. Now, there are some medications that act particularly on dopamine, and two of them are aripiprazole, and the other one is olanzapine. But there's a whole host of these, and these are called antipsychotics because they've been first used in schizophrenia. Now, there's no evidence that people with anorexia have a psychotic disorder, really. But and maybe it's unfortunate these medicines are called that, but that's the way we tend to, what happens in psychiatry. The first thing that's treated, may get a label. But there are we don't have a lot of evidence, the kind of evidence that we would like to have for aripiprazole, which is also called Abilify. There's at least 3 studies in the literature. They're all kind of uncontrolled trials that suggest that small doses of aripiprazole, at least in some people, or aripiprazole with an SSRI, helps to reduce anxiety and core eating disorder symptoms. Now, these medicines are not magic bullets. They don't work in everybody. And one of the problems that we have in behavior is you can't really predict who's going to respond to what medication. So a lot of this is trial and error, but we often recommend if people with anorexia are really struggling with anxiety and difficulty eating because of the anxiety, that they try a small dose of this. Maybe it'll work for them. Maybe it won't. The other medication, at least there's one now controlled trial in the literature that was published last year in the American Journal, is olanzapine or Zyprexa versus placebo. And this actually, showed that people on olanzapine, it worked better than placebo and helped them modestly gain weight. So there's beginning to be some evidence for these medications in combination with SSRI. But this is still, we just need more data. Now, one of the things I want to raise is that as we begin to understand anorexia, you can really kind of raise the issue of, like any other disorder, maybe, the circuit gets impaired, but there's different ways to impair it. Maybe some people have distorted signal about hunger or feedback about energy balance. Some people may have an impaired motivation to eat when hungry. Some people may have exaggeration, inhibition, or anxiety. And maybe, different people have different amounts of these. And what this begins to kind of tell us is how we can begin to target this system in terms of, can we develop improved skills for awareness of body states and insight, better ways to identify and modulate emotions or drives, techniques to increase motivation and decrease resistance, methods to help initiate eating and reduce inhibition, and where dopamine medications may actually be helpful. And so just to kind of give you an overview, because it's really a talk or two in its own about temperament. One of the things that we've been developing is a treatment called temperament-based treatment, which is to say, look, people have these temperaments. They're there in childhood. They get exacerbated when they're ill, but they even persist in mild to moderate forms after recovery. How can people begin to how can we identify, how can we explain these constructs, and what are parent interventions and what are patient interventions? So for example, one of them is undersensitivity to reward and oversensitivity to punishment, or adversity, or things going wrong. And we've developed a way for parents to begin to behaviorally contract with their children with the eating disorder, to really kind of address these kind of issues and work together on actually formulating kind of effective rewards and consequences to motivate them to maintain their weight. Excuse me. Anxiety is a tough one. When by its very nature, when you're very anxious, it gives you a message there's something wrong. You better do something about it. Very hard to kind of suppress really high anxious traits. But we're trying to develop skills to kind of effectively manage anxiety, redirecting distraction, high structure predictability, and medication, and then restricted eating behavior is, again, things that we're working on, how we can set up consistent external structure around meal plans and rules to actually kind of work with people with anorexia, like a lot of structure and are self-disciplined, and and even kind of the idea that maybe it's better for people with anorexia to just eat the same foods in the same amounts every day and not try and act on intuition that when they're hungry. Because some people who have recovered from anorexia have said this to us. They said, well, I've just realized I'm never going to really kind of have signals about how much I should eat. I just put myself on a schedule. I know I have to eat a certain amount every day, and that will keep me from getting into trouble. And they may eat the same foods every day. So in summary, I think this is consistent with anorexic symptoms. How do you explain the fact that they're obsessed with food and count calories and cook for others, yet they don't eat? Well, if you start to look at the systems, people are getting signals, a part of their brain that they're hungry. That signal isn't just getting transmitted into motivation to eat. So they may actually be getting signals that they're hungry, but they just can't act on it. And so they're not being translated into drive to eat. And this, lack of motivation, initiation, they just can't intuitively eat, as I've said. And this anxiety about eating is, a primitive brain system, high risk inhibits the motivation to eat. They may be miscoding food as risky. Now, what about, one of the things I think is very interesting about people with anorexia is it's very hard for them to kind of change their anorexia behaviors, but they're actually great students. They often do very well in school. Now, how do you understand that? Well, you have these different parts of the brain. The subcortical part of the brain that we share with animals and is important for learning from reward and punishment may be the part that's not working so well. The cortex, which is, the part of the brain that you really learn to use that you use in school to learn and memorize and do abstract thinking and act on schoolwork, probably works perfectly well. And this again is another kind of very important kind of thing. I mean, what do you see in people with anorexia that, you go to our program, the walls are covered with sayings and about how to live life and what to do and how to understand other people and how to kind of understand your own behavior. And my guess is what's happening, people are using their cortex to try and kind of make sense of the world and have rules for them to live by, because this intuitive learning from reward and punishment isn't working so well. So I just want to, thank the colleagues that I've worked with in this research and leave a little bit of time here for questions.
All righty, we are back. Thank you so much, Dr. Kaye. That is absolutely fascinating research, and we are really, really honored to be able to hear from you and to learn so much from you. We do have some really great questions that I'd like to just jump right into. First of all, Jessica asks, do you explain to families that anorexia is seen as a brain disorder as opposed to strictly an eating disorder?
It's certainly, the brain is certainly involved, and human behavior is complicated, and it's not just purely brain, and it's certainly not just purely environment. All of us, behavior is a mixture of our learning and culture, whatever, things like that, and the brain systems that we're born with. And trying to kind of parcel out how much it may be different in different people. And some people it may be a lot more brain, some people may be more environment. And we've certainly seen people with anorexia are very sensitive to stress, a parent dies or something like that, and they develop an eating disorder at that point. So it's it's not quite, I'm not trying to give the impression this is just brain, but just so much time to explain these things. So.
Yeah. And a follow-up question is that to that is, do they have a distorted signal about hunger as a child prior to being officially diagnosed? Is there any research on this?
That's a great question, and we've asked that too. It doesn't seem to be. It is for some. I mean, you see some children, and we're doing some studies on this now, and you actually do see some children that have picky eating or other kinds of eating disturbances, but that's not usual. And why this develops, in adolescence around puberty, I think one of the things that hasn't been looked at in, from other fields we know is very powerful influences, and why this may explain why this is so, female gender specific is female hormones actually have a very powerful effect on the part of the striatum, the part of the brain I'm talking about. And it may be that when you start, going through puberty, that these hormonal effects, change this from just a temperament that into, a disorder.
Fascinating. I got another question. What does a clinical presentation of partial recovery of anorexia look like?
Well, it's all over the place. I mean, it's anything from, mild to moderate core eating disorder symptoms or lower weight, eating problems to, being very kind of severely ill. So it's, it's kind of a catch-all phrase for.
Gotcha. If anyone has any more questions, now is the time to dive in with those before I post the CE service survey. Looks like we've got a question from Mary. She says, Dr. Lask mentioned in his book, ED and the Brain, something about reduced blood flow to insula. Perhaps maybe why a person with anorexia nervosa received distorted information about their felt sense of their body shape or weight. Your thoughts?
Yeah, in the last 5 or 10 years, there's been actually a lot of the studies pointed to alterations in insular function in anorexia. And so that, there's been, there's a lot of data suggesting that there is a alteration in insular function.
Yeah, interesting. Great question, Mary. Thank you so much. And just want to mention as well that Heather says, she wrote in here that if anyone would like more information on my red level high alert, and she put her email in there, that people can get more information about that. Perfect. Dr. Kaye, I wanted to just ask you, because you are such a titan in the field, and your research has been so valuable to so many clinicians, obviously, then as well as their clients. And I like how hopeful your message was at the end about how people do recover with treatment and more research and the proper care environment and all these things. People do recover. And I would just like to know from your personal experience, how has it been for you as a clinician treating all of these years to see people recover and see those coping skills move from a maladaptive, impact on their life to something that is really, really powerful?
Yeah, that's a great question. This is certainly I think, a frustrating disorder for people with it, with their families, and also clinicians. And, I think it's, it kind of reframes the course of it. And because now I've seen so many people that followed over time get better and be very grateful about it and do well in life, that, it's made me much more hopeful about this disorder, and I get much less frustrated when people are ill. And I say to the families, look, let's just hang in there. Sometimes all we can offer you is patience and perseverance. Yeah, it didn't work this time, let's try it again. Don't let them die from the eating disorder. Make sure they get enough nourishment to weight gain, stay alive, and the odds are on your side that eventually they're going to get better. Cameron Eddy wrote a very nice paper on this in the last couple of years on outcome in anorexia, and actually, because she looked at this over many years, and actually even found that people were recovering. It took longer for some people to recover, and I give that paper to families because I think that's it's just a very helpful kind of paper, to look at things in perspective.
Wonderful. All right, I think that is it with our questions. Let me just check one more time. We've got one from Therese. Are there any differences in these findings if the patient suffered an early childhood trauma?
That's a good question. I don't. You certainly see this. I mean, you see this is certainly a group of people that's very sensitive. That reports a lot of trauma, and it seems to be sensitive to trauma. And of course, now that we're beginning to understand these systems better, you have to ask the question, even though I think this is difficult, and might be the popular way to look at this is, is this a question for people of being oversensitive, sensitive to trauma that other people, might not see as upsetting, or, is it, are they really kind of having more extreme kind of trauma that's setting this off? And again, it's like the question, it may be different for different people. I mean, I don't think it's one size fits all here.
Yeah, great answer. Thank you so much. And just a nice cool note to end on, Heather said, FYI, though I was not treated for my anorexia nervosa by Walt, I've been working with him since 2015, though I was able to recover after 23 years. So that's amazing, Heather.
Right.
Thank you for sharing that.
It's been very gratifying to work with Heather, and she's just does such a nice job of explaining symptoms, and and that's so important. I think that people, not to be ashamed about this. It happens. We all have certain kind of temperaments, and to start to kind of say, well, there's some good parts of this, and also support change in the field, support research, and support better treatments.
Absolutely.
Yeah.
Wonderful. Well, that's all we've got for today. I am going to send right now into the chat the link to the CE survey that you can complete to get a continuing education credit for Dr. Kaye's presentation. Dr. Kaye, thank you so much. We really appreciate your time and your work.
Well, thank you for inviting me. So thanks. Bye.
Yeah.